I'm Dr. Michael Latola.
And I'm Megan Strong.
This is episode 90, 10 more, and we're into that serious Seinfeld syndication money.
That's right. And on this episode, we're going to tell you why it's probably time to turn off the Justin Bieber.
And in the case of the week, we're going to take a look at some Occlusal Splint choices and the world's most interesting crown prep. That and more on today's Chairside Live. Hey now, hello and welcome to episode 90 of Chairside Live. Megan, do you have any announcements this morning?
I don't have, well, actually, I take it back. I totally do. I am so excited because tomorrow is the premiere, season premiere. It's coming back, people. We've been waiting for this moment. Suits is back on tomorrow night.
Right.
I've been waiting for months. As you all have, as you have as well.
Right.
And I'm rather excited.
I'm currently binge watching The Blacklist.
I've never seen it.
It's James Spader as a creepy, not creepy, but just he's a criminal who has been wanted forever, and now he's working with the FBI to catch all these other people. But he's got a secret personal agenda nobody knows about. Kind of interesting. But if I have time, I have Suits. That's not exactly the kind of an announcement I was looking for. I thought maybe something about you and your child, or you and your...
Everything's going well. There's nothing really to report. I still love cream cheese. And I really want an Oreo milkshake. But other than that, we're good.
Those slightly random cravings, but nothing too bad. We've got an interesting case of the week for you this week. A dentist sent in a case and actually wrote on the prescription form, I'm not sure what kind of occlusal guard to do, what material to use, and I'm not sure what arch to do it on. And that is an area where we can be of some help. We make an awful lot of splints here, and we hear a lot of complaints from doctors and sometimes even from patients about what they like and don't like, and that helps us kind of make these types of decisions. So we'll take a look at that. And a bonus case that was dropped onto my desk about 5 minutes before we started filming, and we'll take a quick look at a very interesting crown prep as well. So let's take a look at the case of the week. I was walking through the thermoforming department the other day, and our splint department, and I saw an RX from a doctor that said, please fabricate a night guard. Please help me with design due to undercuts and rotation of teeth. I'm not sure which material to use or even which arch to do. And that's something we actually see pretty frequently, especially in a case like this. You know, you look at this upper, and you can see that we do have some rotations. We've got a lateral that's tilted to the lingual, and then a central that's out to the facial as well. And anytime we get a couple things like this, especially if we're looking at draw and we rotate this model so we can see, we want to be able to see straight down on that central, and then we see the undercut that we're going to have here on that lateral incisor, and then we'll also look at the sides to see how much retention we're going to get. The teeth appear to be tilted just slightly into the to the palatal aspect, and so it doesn't look like we have a ton of undercut here. So by the time we block out everything, so it's going to go on and off, we're probably going to have something that fits kind of loose, especially like this just happens to be a straight hard splint. This is the kind that we made for each other in dental school, at least at my dental school, and this makes up about probably 15% of the splints that we make, maybe 10 to 15%. And on these hard ones where there's no give at all on the inside, we definitely have to block it out and make it fit looser if we want to have hopes of it going on and off an arch like this. So perhaps a better choice, if you really wanted to do that, would be our hard, soft, extra comfort splint. And the comfort splint, you can take it with your fingernail, and it's got that soft inner layer. So the outside's still the hard acrylic, but the inside is the soft inner layer. And so now there's some give. We don't have to block it out quite as much because we have this flexible layer on the inside. And so that would probably be a better choice in a case like this. But most patients will complain when they've got a couple teeth that are out to the facial, like this central. They will complain that they can't get their lips together when they're trying to sleep. So obviously our mouths usually close and our lips sealed, and then we breathe through our nose while we're sleeping. And this, when you've got some teeth that are facially positioned, it really makes it big and bulky and difficult to be able to get those lips together. So that's not a very comfortable split. So we suggested that the doctor go with the lower, and I dropped this and just broke it. I apologize. a minute ago trying to carry too many things. But as we look at his lower arch, we've got a better chance of the rotations not being a big issue here, even with the incisal edges on those two teeth. It looked okay. And so sometimes that decision between making a maxillary or a mandibular splint, sometimes it almost probably doesn't matter. One way we kind of help a dentist decide is that if there's teeth missing on one of the arch, a couple bicuspids or maybe a molar as well, we'll usually make the splint on that arch to kind of stabilize things a little bit better if we have some missing teeth. If we've got a severe class 2, we're going to probably do it, well, not probably, we're going to suggest that you do it on the maxillary arch, because with the mandibular arch, if we have a significant class 2, we've got somebody who's way back here. If we're going to try to do that and get proper anterior contacts and guidance with the mandibular splint, it's really not going to work. In the case of a really deep curve of SPE, which we don't really have here, that's pretty normal. We're going to go with the mandibular splint for a really deep curve of SPE. And one of the other nice things, a mandibular occlusal splint, it kind of encourages the patient to put their tongue in a better position, kind of the anterior part of the palate, because it wants to sit on top of this splint. And so if it's somebody who could use a little help getting their tongue forward, that mandibular splint is going to be better for that as well. But either way, it almost doesn't matter which one. I know some dentists have very strong opinions about which arch should be used. In this case, though, things definitely look better for the lower, and I'm going to bring a cup of hot water over to show you this splint that we've done. This is one of our flexible splints, and this Astron splint, it's steaming just a little bit, kind of not too hot. I just microwaved that for a minute, but you've probably seen me play with one of these before. These are the flexible splints, so you can see that now I'm able to move it back and forth and this way and that way. And so this is the whole material. There's no soft inner layer. But when we do have an area where we don't want to block out too much, because even looking at this lower, you go, yeah, well, no mechanical retention here, 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 here. Some around the anterior, not really much mechanical undercut here when you look at these teeth. And so that's why something like this, where you can heat it up and pop it onto the teeth, will do a better job. If you were going to do a splint on the upper, you could certainly consider one of these as well, because it really kind of molds itself around those teeth. And so if the patient also doesn't wear it for a couple of weeks at home and they go to put it back in and it's very tight, all they have to do is heat the coffee cup full of water in the microwave for about 2 minutes and heat this up, and this will become flexible again. Put it in their mouth and close down on it and be able to kind of have it re-engage some of those undercuts, or if it felt like a tooth, like on an upper, whenever you see somebody who's got a tooth like this, especially it seems when it's out to the facial, when they put a splint in and it hasn't been in for 4 or 5 weeks, it'll really feel like it's moving that tooth back towards the palatal. It'll feel like you're doing some instant orthodontics, and they'll even get a headache. And being able to heat up one of the flexible ones in a condition like this too will take some of the pressure off that tooth. And so these aren't quite as durable as the other splints, the full hard and the hard soft comfort splint. But anytime you've got some rotations like this, or if we don't have a ton of undercut and we're not going to do any block out, using one of these ones that can be molded either in the operatory or at home by putting it in the hot water out of the patient's teeth can offer a very good solution. And just one bonus case, this is one of the fixed technical support people brought this over to me to take a look at it and said, have you ever seen anything like this before? Well, when I look at this side of the impression, the first thing that I see is it looks like obviously we have half the tooth kind of biting on the tray, so it's probably safe to assume the patient didn't get all the way together on the tray, but it's the impression itself, and actually not a bad job of getting the margins there, but not much in the way of tooth structure besides those 3 little indentations that were prepped. And so when you pour the model, this is what it actually looks like. And if you look at it from the buccal, you'll see that there's not a lot of. That's what I would call a short clinical crown. a very short clinical crown. And so there's those 3 holes that were prepared in the tooth. And again, cord was packed, or a diode laser was used. It actually looks like cord because a diode probably would have left a few kind of tissue tags here and there. A little guessing maybe on the mesial. But I'm guessing this is a vital tooth. I think that's probably pretty clear, or there probably would have been a post and core. And so we've got those 3 little retentive potholes that have been prepared. So you look at this, and even with those 3 potholes, even if this was going to be a cast metal crown, I mean, just the size of the crown, though, to reach the opposing tooth with only those 3 little pegs, you could see those, snapping off quite easily, even if it's adhesively bonded into place with something like Panavia or CNB Metabond or maybe even Total Etch. That's a lot to ask of that. So, maybe the patient didn't have money for crown lengthening, or the dentist didn't want to do it. But you can see we would really be able to benefit from a little additional tooth structure here. And I don't know, I think a lot of dentists would look at that and kind of consider it non-restorable if they, couldn't put some pins in here and build it up too. That's obviously kind of another suggestion would be to put some pins in there and build it up. That's still an awful big build-up for a couple pins, but if you're going to do something heroic like that, that probably stands the best chance. And then maybe if we can grab another millimeter and a half down here for a little ferrule effect, we would end up being okay. Even then, we'd end up telling the patient, I'm not sure how long this is going to last, and I'm sure there's a fair amount of dentists who would either say, look, we almost have to do an intentional endodontic procedure just to be able to put a post and build up in there. And there's probably a few dentists who would just say, oh, that tooth, at this point, not really serving us very well. Maybe it'd be a good idea to put an implant in there. But this just ended up on my desk, and I thought it was curious because I'm not sure there's any way we're going to make something successful there. But I've never really seen something like this done as well, too. The dentist did prescribe a PFM crown, so it's not like it's going to be anything, some sort of kind of tricky crown. It's just going to be a PFM crown with 3 little legs in there. But if anybody knows what the dentist was trying to accomplish here and whether you've done it and if it actually works, please drop us a line at Chairside Live and let me know. Otherwise, I just thought it was kind of curious and something that I wanted to share.
Thank you for that, Dr.
You're welcome.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Aziel Peters from Chandler, Arizona, and he writes, Hello, Dr. D and Megan. I have a couple questions about a case I am doing. I am placing veneers on 6, 7, 10, and 11, and I want to use the 3-in veneer cement kit. Is this the best way to cement them? Second question is, do I have to place 6 and 7 at the same time, or can I place them one at a time for better control? I'm thinking of using a Mylar strip so the cement doesn't get bonded onto the adjacent tooth. And then his last question says, if the temporary veneers don't have much mechanical retention, can I spot etch the middle of the tooth, bond it in the same spot, and place flowable composite around the edges of the temp? Lastly, which bonding agent would I use? Thank you.
Well, and thank you for printing a copy of this. There's just a few questions there that need to be answered. So let's see, you're doing veneers on 6, 7, 10, and 11. So 8 and 9, I'm guessing, probably already have crowns on them. Probably not virgin teeth. So they probably have restorations on them already. And if they're anything like the majority of the restorations we see here at the lab, they're probably bulkier, these crowns, than the virgin teeth were. And the reason for this is because as dentists, we like to be conservative. So we have a tendency to under-prepare teeth and not prepare enough off the facial surface. And dental technicians, on the other hand, in the name of aesthetics, have a tendency to overbuild things to get enough depth so that something looks like a natural tooth. As a result, in some of the studies we've done here at the lab, almost 90% of the crowns end up getting bigger when compared to the original virgin tooth. So for example, on a posterior tooth, it can only grow buccal and lingually and get wider that way, and it often does. And on an anterior tooth, really the only place it can grow is to the facial, and it often does as well. There's a reason why you can take a Yellowstone model and any dentist can just glance at it and go crown, 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 without having to see pictures of the teeth. and it's because of the anatomy or the lack thereof, or the fact that the teeth look slightly pregnant, no offense, or like they've been stung by a bee and now they're a little bit swollen. So if 8 and 9 do in fact have crowns, doing veneers adjacent to that can really make those crowns look better and make the entire smile look better as well. You're going from 6 to 11 on the cuspids. I stopped doing that years ago because when I take photographs, it looked like I couldn't see the first bicuspid. So typically, if I'm going to go to the cuspids and do 6 and 11, I'm going to move one back and do the first bis as well. In fact, I'd rather do the second bis too, because that way the buccal corridor is going to look fantastic. When the patient smiles, it's going to look like Julia Roberts, where you just see that whole wall of teeth, or like Whitney Houston pre-Bobby Brown, where she would smile and you could see all the way back to the second molars, maybe even the wisdom teeth. So sometimes stopping at the canines, you just lose the first bi behind it. In fact, oftentimes, if I have crowns on 8 and 9, I'll just put veneers on 7 and 10, or go all the way back to the first, or preferably the second bicuspid. So I know you didn't ask that. I just thought I'd throw that out there. Yeah, the Reliax veneer cement from 3M is fantastic. Essentially, all veneer cements are regular composites that have had the viscosity changed so that you can seat a thinner veneer without much effort and without possibly cracking the veneer. At least the older types of veneers that we had, when they were thin, they were prone to breaking if you were going to push down onto a regular composite and put it into place. Basically, the two things that I look for in a veneer cement, I want to make sure the tri-end shades match the final shades well, and I want to use a light cure only veneer cement, because anytime there's a chemical cure, there's a chance that the shade of the veneer cement will change colors or change shades over time. In fact, I've seen a couple lawsuits in the literature where 3, 4, 5 years after the patient had them placed, some of the teeth, the cement started changing shades and getting lower in value, getting darker, and the patient was rather upset with that. The 3M product, the light cure version, will not do that, so you're fine there. Do I have to place 6 and 7 at the same time, or can I place them one at a time for better control? I tend to place them at the same time, and mainly just because I don't want to lock one of them out. You know, I don't want to put 7 on and have it seat just a little to the distal and not be able to fit 6 on. You know, with veneers, for the most part, unlike crowns, they're kind of low retention preps, and so they have, especially no prep veneers or minimal prep veneers, have a tendency to kind of float, and they can move back and forth on the tooth as you seat them. And for that reason, I like to seat them at the same time. But if you do your tri-end, if you take 6 and 7 with the tri-end paste and put them in, and there's no contact issues at all, and boom, they just both go down into place, and then you take, let's say, number 7 off and 6 seems pretty solid, or you take 6 off and 7 seems solid, you could do them separately. I mean, it's not a big deal. The only downside would be if you put 7 on and then went to seat 6. And if you do put 7 on first and bond it into place and clean it all up, make sure you try on 6 again before you go right to the cement and then find, it won't seat all the way, because you might need to adjust that contact once you have put 7 down into place. So it's really up to you. That's kind of personal preference. You're thinking of using a Mylar strip so the cement doesn't get bonded onto the adjacent tooth. I'm guessing you're talking about between 5 and 6 so that you don't get composite. I've never quite liked doing that and never really come around to doing it, especially with the Mylar strip. Maybe with a dead soft metal matrix band, I'd be okay with that. But there's always some thickness there that can keep the veneer from seating all the way. As long as I have a serrated strip of some kind, one of those metal strips like the one Axis makes, and it's got that saw edge on the bottom, regardless of how much cement gets between the teeth, I'm going to be able to saw through that contact. So I prefer to seat them without that. I know Denmat, I believe, teaches all their courses where they put the Mylar there, and those are successful too. So again, that's personal preference. I'd rather just make sure I get it down all the way and then saw through it afterwards, although God knows that's not a ton of fun to do. If the temporary veneers don't have much mechanical retention, can I spot etch the middle of the tooth, bond it in the same place, and place flowable composite around the edges of the temp? Lastly, which bonding agent would I use? Yes, you would spot etch it in the middle with just regular 37% phosphoric acid, leave it on for about 10 seconds, rinse it off. Which bonding agent would you use? Well, it depends. We don't really want to get a strong bond here, so we are just going to put the bonding agent right in the middle. So I just always go back to one of my 4th generation Denton bonding systems like Scotch Bond, where it's got the 2 separate bottles. You've got a primer and an adhesive. In later generations, those were combined into the same bottle, but in those fourth generations, whether it's Scotch Bond or Optibond, they came in different bottles. And the primer part is what helps it bond to the dentin. And so if you use the adhesive, you don't have to worry about it bonding that strongly. So I will actually spot etch in the middle, and then I will just paint adhesive over the entire tooth surface. So you're going to get a little better bond where it's spot etched in the middle, and you'll get it a little mechanical retention, but you'll be able to scrape the rest of that bonding agent off the unetched enamel, if that's what it is, or dentin, when you go to remove it. And I would take the flowable composite and just fill the whole veneer. You mentioned just putting it around the edge. I don't know, that seems like potential leakage or bubbles or just different optical effect. I would not be worried about that with the temps. I would just fill it with the flowable composite, put it into place, take a little brush, clean up as much as you can. You could even run floss through if you wanted before you cure it at that point. But my favorite way is to lock them into place with that putty wash matrix, either of the original teeth or a diagnostic wax up, and just lock them in. You have to be careful. If the patient goes to a bachelor party and smokes a bunch of cigars, they will get black stain underneath it and some other food. So since there's no cement layer under those mechanically retained temporaries, you do have to be careful sometimes. But best of luck. Let us know how it goes. That's quite a puzzle that he's got here that he wants to put together.
Right, and to help him with that, to help him prepare, we have got a 30, not 20, not 10, 30-piece Chairside Live puzzle.
Wow.
Yeah.
That's, again, I've mentioned it before, 30 pieces is not a lot. 500-piece puzzles are considered slightly challenging.
Okay, he's got a busy schedule.
That's true.
Full patient load. So let's, he's just, maybe on his lunch or whatever, he'll put it together and feel accomplished and then be ready to go put this puzzle together.
All right. So yeah, do the puzzle first over lunch, feeling of accomplishment, and then go bond in some veneers.
There you go. And then also to sweeten the deal, since there were so many great questions in there, how about an autograph photo?
That sounds fantastic.
Yeah.
And again, we're looking at each other both with curious glances.
I wonder what was being said. This was the last episode, and I could only imagine.
My, you look, I like yours. I look like kind of a face of an inquisitive ferret.
That's such a strange thing to say.
I've spent more time around ferrets than you have, but
I don't even want to
You
ask.
definitely look better. I can tell you pick these. You always look better than I do.
never pick them, actually.
Well, somebody who likes you picks them.
Well, okay. Well, Dr. Peter, this is going straight to you.
I'm going to sign his puzzle. You got any news?
I do.
Thank you.
Do you play music in your dental office? Studies show that music has many relaxation benefits and can actually improve one's mood. When it comes to easing a patient's anxiety, it has to be the right kind of music. Avoid elevator music, as research shows that it can be annoying. The most effective choice for dental offices are either paid streaming music services or an iPod playlist that has soothing, widely appealing songs, such as the Beatles, Jack Johnson, and more, and without commercials. Play the perfect music and you could get more patient compliance, improved communication, a more positive view of your practice, and more.
It's funny because when you sent me that story, I looked it up, and the one of the experts that they are quoting in here is a guy that says he's a music atmosphere consultant and a working DJ.
Wow.
And he lists his top 10 songs that are, quote, harmless, enjoyable tunes. And I think that's kind of a funny description. So one of them is In My Life, the Beatles. Number 2 is Three Little Birds by Bob Marley, popular on many college campuses around the States. And really good with nitrous, I would think.
Oh, gosh.
Or in Colorado or Seattle with the marijuana. I liked Tempted by Squeeze. Now, that's a band you probably don't know from the 80s.
No idea.
Great band, great song, all about infidelity and all about
Great.
cheating.
Wonderful.
And I was like, well, I don't know. I guess that's harmless, unless the patient you're working on just found out her husband was having an affair.
Then it would be
Then it'd be very
harmful.
sad. Yeah, then you'd have to hit her with Three Little Birds, Little Nitrous to probably make that. I like to have a Fleetwood Mac song. A lot of great Fleetwood Mac songs. The one they have listed is Never Going Back Again.
I haven't heard
and
that.
I'm like, well, why would you play that in a dental office? I mean, you're giving the patient idea. I'm never going back again.
Yeah,
that injection,
not a good idea.
that hurt. I did not enjoy that. And I thought that. And then Moonshadow by Cat Stevens, who famously changed religions later.
I don't
and a lot of people
his
feel
name's
that.
like Ishmael now, right, or something?
I don't remember exactly what it
Yamo,
is.
or it's something.
Oh yeah,
Yusuf
Islam, and
excuse me.
that never bothered me. His music's still absolutely
Yeah,
fantastic. I have vivid memories of being in my mom's station wagon, being driven around when I was a kid, and hearing those songs. But I know I just thought that's weird.
Wait, in the actual station wagon or in the trunk?
No, that was a different car.
Gotcha.
This
okay.
was I was actually allowed in the passenger compartment.
Oh my gosh. Okay.
This time.
Sorry to ruin the story. I'm sorry.
With my mother. So I don't know. It's funny to kind of hear this. Every time I go into a dental office, I'm always kind of thinking, this is curious. You know what we're going to see. There's been times where my assistant, I used to walk into the operatory and it would be KROQ, an alternative rock station.
Right.
And I was thinking, this is a little too much.
Right.
You know, for some of these patients.
Sure.
I used to have a sports radio show that I'd call into, and sometimes I would play that, and I thought, you know what, this is probably annoying a lot of people too. But there are some really typical, I can't think of any off the top of my head, but songs when you hear it, you go, oh man, that's a dental office song. Right, and whether it's Skyrockets at Night, which is another one, I don't know if it's harmless, you probably don't remember, a song called Afternoon Delight.
Oh, yes.
About exactly that.
From, I actually know that from Anchorman.
Yeah, exactly, showing up in a movie like that. So, yeah, unfortunately, I think this is one of those times where you're probably just better off putting together a playlist of mellow stuff that you enjoy. You can't, how are you going to satisfy all 2,500 patients? You have to just have something where, while you're sitting there knee deep in a molar root canal, you can at least kind of tap your foot along as you're filing, you know, and think to yourself, I like this music. I don't know if anyone else does.
And in addition to music and creating like the right atmosphere for patients, I've always wondered, I went to the same dentist for years, like basically my entire life, and recently changed, but both of them had the same like ocean themed decor. What is up with dental offices and dolphins? There's something about dolphins and dental offices. I would like to see how many viewers right now in their practice have dolphins.
Yeah, I actually know a guy down in San Diego, great dentist, good friend of mine, where there's dolphins in there as well.
And I would assume that it's because it's soothing, they're playful and happy and whatever. And I have nothing against it. I like it, but and the one I go to now is like right by the beach, so it makes sense. But that always struck me as
the one I'm thinking of. The reason he has them, he's a big fan of The Cove. I don't know if you saw that movie.
Nope.
Loves to eat them dolphins. That's
oh gosh.
No, he does. That's not what he does. I was just kidding. Anything else?
Yes. A 4-month-old baby in Maryland may be the first person to have teeth grow in his brain, the result of a rare brain tumor. Doctors were concerned when the baby's head was growing faster than is typical for kids his age. A brain scan showed the tumor containing what appeared to be teeth. They performed surgery to have the tumor removed, and doctors found it contained several fully formed teeth, according to the report. Teeth are commonly found in tumors called teratomas, but it's unheard of to find teeth in the type of tumor this little boy had. The boy is healing and progressing well in his development.
And I remember in dental school learning about teratomas and seeing pictures, and it's tumors with ectodermal cells on the inside. So they were showing examples of these tumors cut in half where some had teeth, some had hair.
God.
There was hold on, one
hair.
more. Fingernails growing inside some of them.
Seriously, I can't, I'm trying my best to stay composed and professional. Right. This is absolutely disturbing, and I want to run away from the desk right now. I know. And the good news is they didn't give the person's name, the child's name. I'm sure they get mercilessly teased at school, if it came out. But the baby's fine. He's fine. All right, that'll about wrap it up for this week's edition of Chairside Live. On behalf of myself, Megan, the whole CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry. Come back next time. I don't always drink, but when I do, it's Dos Equis. Trying to think what it'd be for the world's most interesting crown crab. She's a brick house. A 4-month-old baby in Maryland may be the first person to have teeth grow in his brain, the result of a rare blah, 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 go up. Sorry. All right, let's just. Hold on. Sorry. That's okay. Oh gosh, Clarice. I look like kind of a face of like an inquisitive ferret.